CEO and founder of Light 365, and welcome to Season 3 of The New Normal. Today's episode will discuss the changing economics and dynamics of patient care, transitioning to home. Before I introduce our panelists, I want to take a minute to thank you for joining us today, as well as thank our panelists for sharing their time with us this evening. As for the structure of this webinar, attendees will be on mute and will be reserved time at the end for questions. Please place your questions within the chat. You can review the recording of today's webinar at www.newnormal.buzz. Now I wanted to introduce our distinguished panelist. Randy Nale is Director, U.S. Healthcare Solutions for Microsoft. Randy is a healthcare technology leader that has been helping to drive the digitization and digital transformation of healthcare for 25 years. From strategy to design to implementation, his career has offered the privilege of working with some of the best and most innovative healthcare and technology organizations on the planet. Together with brilliant physicians, clinicians, and technologists from those organizations, he strives to make healthcare better, faster, and less expensive. Dr. Farrukh Jafri is Medical Director of WPH Cares, White Plains Hospital. Dr. Jafri is the Medical Director of White Plains. He is an experienced medical doctor who is skilled in clinical research, medical education, digital health, community outreach, patient safety, and quality improvement initiatives. His research interests include the use of technology to advance healthcare delivery and is enrolled in a Doctor of Philosophy, PhD, focused on quality and performance improvement from Harvard's MGH Institute of Health Professions. And then Michael Latchmansingh is Manager of Innovation Implementation Operations for White Plains Hospital. Michael is the Implementation Manager for East Post Road Ventures at White Plains. He received his BSNRN degree from Bingham University and worked for Georgetown University Medical Center, SICU, before returning to school in a non-traditional nursing path. He returned to graduate school and received his law degree and MBA concurrently from Albany Law School and Union Graduate College, respectively, while working for the Office of the Medicaid Inspector General and the Albany Stratton VA Medical Center, ultimately returning to the tri-state area to work in risk management for a community hospital in the Bronx, and eventually in risk leadership for a large internationally recognized teaching hospital in NYC. Michael applies his years of experience in workflow and process analysis and a specific emphasis on potential failure points and mitigation strategies to his role as implementation manager. All right, so welcome guys, a very impressive background. I'm gonna try to keep up with you. So you guys were off to a brilliant start. So I'm gonna start off with, to provide some context, I'm gonna ask the panelists to briefly share some information regarding their current roles and organizations. So Randy, let's start with you. Can you please provide a brief overview of your role and the core products that encompass Microsoft Cloud for Healthcare, so attendees have an idea about the platform capabilities?
Yeah, thanks for that, Kit. So a little bit about my role. So I'm a part of Microsoft's U.S. healthcare business. So we have a dedicated healthcare business here in the U.S. In that business, I lead what we call healthcare solutions, or I think about it more as healthcare solutioning. I think as most people know, Microsoft provides a broad set of cloud platforms on which our customers and partners build and implement, things that are unique to them and solve their specific, challenges and scenarios and use cases and those kinds of things. What's a little different about my role is that Microsoft, about, a couple of years ago now, really October of 2020, made generally available the Microsoft Cloud for Healthcare, which adds healthcare specific features, functions, and capabilities, things like health data services, healthcare AI, healthcare experience platforms, those kinds of things, on top of our horizontal cloud capabilities. And so my team and I really lead the charge in working with our healthcare provider customers, payer customers, life science customers, and even healthcare solutions customers, implement those platforms and build, innovative solutions on those platforms. So. Great to be here, and thanks for having me.
Awesome, and great to have you here as well. I'm going to go to Dr. Jafri. Can you briefly describe your role as medical director at WPH Cares, and what is WPH Cares and why was it started?
Of course, and thank you, Kent, for having me on this podcast. WPH Cares is a program or a department out of White Plains Hospital, part of the Montefiore Health System, that focuses on patient access. It's about access to care and access to services. And it focuses on getting access to what patients need at the time they need them, when they need them, and no matter where they are. So as you can see, it really lends itself well to innovation and really the future of healthcare, which is either digital transformation, hospital at home, and there are a lot of different avenues where we could go in regards to this. To keep it short, there's a lot that WPH Cares is involved with, whether it's telemedicine, virtual care, telepharmacy, remote patient monitoring, remote therapeutic monitoring. And so there's a lot that we can discuss, but the core of what we do is getting access to care and access to services, and really focusing on health equity.
I'm going to stop really quickly. Michael, I'm going to go to you in a second because you need your time as well. But a lot of people throw around the term hospital at home. What does that mean to you in White Plains?
You know, hospital at home to me focuses on being able to deliver care outside of the four walls of the hospital institution and really expanding that care or hospital level care to the individual's home itself and being able to provide certain services outside of those four walls.
So is White Plains right now a official CMS waivered hospital at home, or is this something you're adopting yourselves to implement?
Not yet. We're not at the hospital at home level. I think what we are beginning to start exploring is being able to deliver care at home and build ourselves towards a hospital at home program.
Awesome. Great. So Michael, on your background, can you provide a unique perspective on healthcare economics and operation? You can also chime in on hospital at home, your thoughts as well. And can you briefly describe your role in innovation and implementation management at White Plains?
Firstly, Ken, thank you for calling me and Dr. Jafri distinguished. That may be a first. No, so I'm the implementation manager here at within the innovation arm of White Plains Hospital, and essentially what my role is when the innovation group has identified a new cutting edge technology, medical device, workflow, what have you, we try to, if it's early on in the stage of, let's say, startup, figure out a way to collaborate with that organization, with that startup, invest in them, and then help them grow while simultaneously finding places and ways to implement and operationalize their ideas and their novelty within the White Plains Hospital health network and health system. That's a big part of my role here, specifically with my interactions with the WPH Cares team, which is a good portion of my role here is, I think, helping Dr. Jafri and supporting him with whatever he may need in order to help scale his projects and his role within the WPH Cares team. And between the Life 365 platform and some other tech that we're looking to deploy or are deploying, we're really trying to figure out those ratios of how many patients we can adequately or really exceptionally monitor, optimize, and have that hospital at home while utilizing as best as we can our internal resources of NPs, RNs, and Dr. Jafri himself.
The one question that always pops up on this, and I think I already know the answer, but I'm going to ask you it, is the pressure of going hospital at home or having patients being at home now instead of being in the hospital. Doesn't that put more pressure on your hospital system to try to put people in beds in the hospital instead of being at home, right, to fill up the beds? Or are you going to start shrinking the footprint of your hospitals and consider the home an extension? How do you visualize that for the future when you're building hospitals for the future?
I mean, I could touch that
Sure.
question. So, I mean, you're coming to the base of it, which is, focusing on hospital capacity. And
Yeah.
I think, once, there's a quote that I've heard, I can't tell you where I attained it from, but basically, once a hospital reaches 100% capacity, that means that hospital really failed in regards to its planning. And so, with the COVID surges that we've experienced, and the unclear future in regards to what else is out there that will be impacting hospital flow. I think the important aspect of it is, and for me, I have a performance quality improvement background. For me, this is a quality improvement initiative. Is how do we extend the capacity of hospital care and improve the quality of care while delivering the same level of quality at the patient's home? It's not only about capacity in itself too, it's also about really the right subset of the patient population. Hospitals are fantastic for acute care, but for certain patient populations in certain situations, the same care can also be delivered at home. And it's also about quality of life. For some elderly patients, it's important for them to, be at their home instead of the risk of deconditioning that can happen in the hospital. There's a risk of infections at the hospital, more so than at home. And there's also the concept that, some patients not only will be more beneficial in regards to the care that they're able to deliver at home, but to be able to deliver certain services. There are cases where I've had patients with resistant organisms in their urine that otherwise look fine, but they're admitted to the hospital for 10 days of IV antibiotics. That's 10 days, 4 times a year that they're in the hospital instead of at home, functioning, being able to perform at their capacity, being able to perform at their job. So it's quality of life for the individual and also quality of care that we're delivering at the hospital.
Yeah, it's interesting. I was reading a study yesterday that was looking at the hospital at home initiatives, and they said, people, number one, prefer to be at home, right, in the first place. But second of all, that people are actually in bed less when they're at home, right? In the hospital, they tend to stay more in bed and less mobile. But the interesting thing was they're like that we have to determine what services to provide to the caregivers, because the caregivers a lot of times need a respite, right? And they're taking people to the hospital so they have a respite away from taking care of sometimes the patient as well. So when you're addressing, hospital at home, sometimes you have to address the caregivers too in that whole equation.
No, absolutely. And it's a complex care process. And I think all of this really needs to come into play when it comes to being able to deliver this care at home, and who's the right patient, what's the right scenario that you should be delivering this care. And all of these factors need to come into play. And there are places that have really done this successfully in regards to the whole triage process of the hospital at home system, with very high patient satisfaction scores in addition to that too. And you touched on the caregiver support model, and that's really an important aspect of what's the appropriate inclusion criteria for a hospital at home. And so, it's a huge topic in regards to what's the right patient, what's the right population, what's the right support to be able to deliver this amount of care.
Right. So Randy, I'm going to go over to you really quickly. I'm assuming that we're starting to go outside the 4 walls of the hospital, that, technology and data are going to play a role, right? To be able to link services and solutions together to enable healthcare to be performed outside the 4 walls of the hospital. So just tell me a little bit about some practical scenarios where you're doing at Microsoft to help support the hospital at home initiative or the virtual care initiatives.
Yeah, I would say, there's lots of places to go. So I'll just, and for the sake of time and scope, I'll just touch on 2 really quickly. So the first is, we believe that in order to be able to capture the volume, frequency, also called velocity of data that is going to be required in order to, care for an individual in their home, that you're going to need a cloud scale healthcare data service. So one of the first things that we did when we began to extend our cloud with healthcare specific capabilities is we built a native healthcare data service. And it's not only the cloud scale that comes into play, but if you think about, how historically customers or like White Plains or partners like you all at Life 365 would have built a solution in the past that needed a healthcare data service, you would have sort of, gotten some storage, you would have gotten a database engine, you would have either bought or built a data model, then you would have built sort of an API for accessing that data on top of that had, authentication and authorization. So you would have had to kind of build this whole stack of things, right? And with our healthcare data service, you can literally say, and you can go into the Azure portal and say, I want a new healthcare data service. And what you'll get is, an elastic data service that has the storage managed for you, has the data model based on the FHIR specification, has an API, has authentication and authorization, has all of that. And you don't have to build anything. You could just start using it, and you can be confident that it's based on open standards, so that you're sort of not locked in, which is the case with many of the healthcare systems that we know. So the first thing I would say is you need a cloud scale healthcare specific data service to sort of land all of this data that is needed for these initiatives, right? So we built that. The second thing is you need the what I would think about as the plumbing for all of that data that's coming in from those devices. So Microsoft, not to do too much of a commercial here, but we have, we're a market leader in IoT. So what we did with that was we took the underlying IoT platform that is already in place and that we've had and that we've been leveraging with customers for quite a while now. And we've built extensions onto that IoT platform so that as the data comes in from the devices, it can be translated to health data. So in other words, you might get off of a blood pressure device, some randomly formatted data that represents a blood pressure reading, but how do I interpret that? And so we built a set of tools on the end of that, or into that IoT platform, that as that data is coming in, you can use templating and automation to automatically convert that to, for example, a blood pressure observation and land that in your healthcare data store for use downstream by systems and processes and people and all of that. So data and technology, I think, play a huge role in the way that we're trying to help our customers and our partners is sort of empower them to be able to build higher in the stack and not have to spend a lot of time down in the weeds and the plumbing and the, all of that. So I would say, again, we could go a lot of places, but that's two that I think where we're trying to make a difference in helping folks like White Plains and yourself.
Yeah, so I think White Plains, you guys are on Epic, right? From that standpoint, and you obviously, Randy, you guys are connecting to Epic. Where does Epic start and stop, and where does Microsoft Cloud for Healthcare? Is it a bolt-on to Epic, right? And kind of a front end for conditioning and formatting data? What's the role between Epic and Microsoft?
Yeah, that's a complicated question. Whatever you say, Epic at anything, that's always a complicated question. But I would say at its core, though, Epic we think about Epic primarily as the system of record for the clinical system of record, if you will. So if you want to know the authoritative diagnosis, therapies, medication lists, whatever, the source of authority is the electronic medical record that's capturing the, official record, right? Well, every reading that's coming in off of, let's say that, it's a device out in this hospital at home or remote patient monitoring that's sending in, readings continuously. Is it appropriate to store every single one of those readings in the clinical system of record? Or is it more appropriate to sort of gather those up in a cloud scale, healthcare clinical data, service, and then post the outliers as a part of the clinical system record and have that posting be driven by workflow that's affirmed by a clinician, right? So do we want the system to automatically post in a reading that hasn't been vetted by a clinician? I'm not a doctor, but perhaps not, right? So perhaps we capture all of this data that's coming in off these devices in the clinical system of record, and we drive automated workflows that basically go, hey, this one looks weird, or I have a series of, things that are outliers or, above or below a threshold or what have you. And then that flags a workflow for a clinician or somebody else to sort of go take a look at that and go, yeah, I need to log that into the clinical system of record. And then that will drive a workflow that maybe is an outreach or, put them on a list to call and check in with more frequently or whatever. So we see sort of Epic or other EMRs as the clinical system of record, number one. And number two, the core workflow engine, if you will, for the clinician or the physician. They want to work in that system because that's what they're used to. And we complement that at the end of the day is sort of how we think about it.
Michael, I'm going to go to you next, but I kind of refer to Microsoft Cloud for Healthcare as a super platform, right? Like you're out, connected to all these other platforms that are out there and aggregate them into one place. As we know, Athena goes to their marketplace and Epic goes to their marketplace, and others that are out there, Cerner to theirs as well. I kind of see it as aggregating that all together in one place.
Oh, and as just one more thing, as M&A continues in the healthcare industry, and the cost of migrating EMRs and all that data and everything just continues to grow and complex. Like how many large enterprise healthcare systems today have just one EMR or just one instance EMR, and then how many will have that as we continue to do this M&A activity, right? And so Microsoft, again, represents that sort of meta platform. I don't want to overuse the word meta here, so I'll use super, like you said, the super platform.
Right. Okay, that's great. Michael, let me ask you a question really quickly. Given everything that Randy has just said about the Microsoft platform, how would that relate into White Plains? How could you leverage it and use it, right, to get more functionality out of Epic or your existing data you're receiving, or help with transition of care to home?
Well, first, I want to comment that it sounds like Randy and his team are trying to get Microsoft to supplant Epic and being on the provider side of things. No? Okay. Yeah. Well, if anyone could, it would be Microsoft, because a lot of people are getting pretty tired of working with Epic, to be honest.
It's a great Microsoft partner. They build on our platform and
okay, so it's a symbiotic.
You're getting him in trouble.
Yeah. I think they want to be an aggregator to kind of be open and agnostic to any platform that's out there. That's my read on it, at least.
And before I answer your question, Kent, one thing I did want to touch on that Randy mentioned that actually I never thought of before, and Dr. Jafri might be good to explore further, is I think you're hinting at the concept that there is such a thing as too much data, especially when it comes to healthcare. If you ask a provider, or at least in my opinion, I disagree. But if you have a patient who's willing to measure their own vital signs, hourly for the entirety of a year, once you've established a clear baseline, is there really any value in that data beyond whenever it pings that it's outside of a threshold that we want to monitor? And then does the record in that case have some kind of machine learning functionality to it, where it just establishes a patient's baseline based on all that data, reverts that information back into the record, and it only includes then the baseline and any sort of aberrations? And that would be actually a very powerful and helpful tool if we're trying to minimize the volume of data and sort of filter that noise for real meaningful information. But to go back to your question, Ken, it's a lot of exactly what Randy's describing. I think it is, at least in my role and how I view things, more on the WPH Cares, on the ambulatory and the transition of care side, where if we can help, if it can help with scalability, where we're rapidly reaching a point where the devices that perform these measurements are becoming more and more affordable each day. New competitors enter the space, and the cost of creating them, manufacturing them, and providing them to a patient is becoming, I don't want to say negligible, but almost offset by some fairly modest CPT codes within the CMS regulations. What will likely never offset, and remote patient monitoring platforms, I think internally we've accepted won't be profitable, but would at least reach net zero while simultaneously increasing the quality of care that we deliver and helping us avoid penalties from readmissions and keeping patients at home longer, where they're not falling like they do in the hospital because it's a new space, where they're not miserable, where they're not taking up a bed when someone with a more acute illness really needs that bed. I think Microsoft's ability to be useful for us is with that sort of scalability, because the largest cost of any of these types of programs is the labor. An hour of Dr. Jafri's time, and an hour of an NP's time, an hour of a PA's time. I actually, I don't know offhand, but back of the napkin sort of accounting, you might need to assess, 100 patients or 250 patients a month to sort of break even. But to make that manageable or even scalable to an nth degree, if a player like Microsoft could enter the space and create an overlay where it ingests the data that Life 365 platforms and the various third-party vendors that create these devices that slot into the Life 365 platform, it ingests that data and then brings the aberrations to the attention of Dr. Jafri or to the attention of one of his PAs or NPs to say, hey, Mrs. Smith is usually 80 over 120. She's suddenly 140. While that's not a big deal theoretically, if you have enough data to back up that that's statistically significant, all of a sudden you're creating an intervention that in its extreme sense might prevent a hospitalization. In its most minimal benefit is at the very least, a touch point and a check-in and another opportunity for a clinical person to reinforce best practices with this patient. But either way, you're increasing quality of life. But in my opinion, that those sort of ambulatory, hospital at home, remote patient monitoring spaces is really where us on the provider side can get a lot of value leveraged out of Microsoft and other data analytic tools.
Yeah, I think for me, when I'm listening on this, I think a lot of this focuses on how the data is being visualized, right? I mean, you said there's no such thing as too much data. Well, for me, it's about how is the data viewed and how do our stakeholders evaluate it? Like if I give a cardiologist, a list of blood pressures for 20 of their patients on like a Friday at 4 p.m., or if it's just like kind of in the EMR, but it's not done at the time before their appointment, or it's not done in a way that is part of their workflow. If it's more work for them, it can be really more of a detriment. So how are we presenting this data to them is important. And when I think about remote patient monitoring, hospital at home, really I see two avenues for this. One, you kind of already talked about it, is add more abnormal thresholds, right? Like, are we able to prevent patients from harm by evaluating an abnormal threshold? They drop their blood pressure, they drop their oxygen saturation, whatever it may be. But the other opportunity, and I think this is something that is probably going to hopefully start growing more and more, is the opportunity to be more proactive in the management of chronic diseases, even in the ambulatory setting. If you're talking about diabetic management, congestive heart failure, COPD, so you don't have to look at abnormal thresholds as much as you could look at, are we getting these patients really to a more optimized setting in a way that we wouldn't have done before, protocolizing it. But ultimately, the question is, how do we bring this data? And I think having a player like Microsoft will be huge in this field, because I'm so used to looking at data and looking at it in the weeds, and the struggle that we're having and the barrier that we're having is, how do we now present it in a way to our stakeholders, both the patient as the stakeholder, because this is really, it's not really remote patient monitoring as much as it is co-monitoring, as well as the stakeholders that we're dealing with, like the cardiologist, the primary care physician, the endocrinologist, in a way that's meaningful for them, that's timely for them, and that's actionable for them. And that's where EMR integration is going to be important, because what we've noticed is if you don't have full EMR integration that's actionable, it can really be more of a barrier to care. We're telling our primary care physician in the middle of their 30 patients a day, don't forget to log into this, log into that, look at this data, and don't forget that that's your patient that you're seeing today at 10 a.m. It's not going to happen. It's got to be a way that makes their lives easier. And I think that's what we are really trying to figure out.
Cool. Randy, I was going to ask you a question really quickly on this. On everything that's being said, really data is the key for your input, at least getting data in from the home as part of the transition of care to home. And you want actionable, meaningful. To Michael's point, you also want economic data that's acquired economically, right, as well. You can't give everybody a laptop and say, get your data and bring it in. So I think one of the things that we've worked together on, and also White Plains have worked together on, is trying to align the right solution with the right patient to try to get the right data, to get the right outcome at the right cost to do that. And one of the things that I think is a benefit of an aggregated solution like on Microsoft is that places like White Plains they're probably approached 200 times a month or maybe a year by disparate devices, right? That they have to go through IT security and Epic. You know, that occurs in what, guys, a week or two, right? To go through IT security in the background. But if they integrate to Microsoft once, you then give them access to 300 different health systems, hospitals, and others that are out there as well. And that now starts taking their interoperability. Now you've got contracts with those hospitals, you've got integrations with those hospitals. You now allow these devices now to interface once and for data to flow through any of the hospitals that you're interfaced to without them having to do their own interfaces. So is that kind of how you somewhat view the world, right? As far as data collection and, you know, getting actual data into your models?
Yeah, so I think so. I just wanted to clarify a couple of points there, though, and maybe elaborate just a bit. So first of all, around the too much data, Michael, when you said you know too much data and we wouldn't have to store all that, the beauty of the cloud scale healthcare data services is that you can keep all of that data and store it if you need it, but you don't have to put it all as a list of transactions in the EMR, if you will, right? So the data is there. You just want to Dr. Jafri's point, you want to put the relevant stuff, you know, in the workflow and put the other stuff over here that we got it if you need it, you know, but we don't shove it all in there so that the clinician has to sort of filter through all of that on their own, right? So that's part of it. As far as the data flowing and all of that, Kent, one of our guiding principles at Microsoft that I think is a little different than perhaps, you know, other technology companies is, you know, and it aligns to our, again, trying not to get too salesy here, but it does align to our mission of empowering others, is that we feel like a customer's data is their data, and we shouldn't have any control over how it's used or where it's routed or who it's sent to or who it's shared with. Like, we shouldn't have any control over that, right? So what we do is we allow customers like White Plains to sort of build their own instance or stand up their own instance of our cloud services. So I've been using the Azure Health Data Service, so I'll continue to use that over and over again. So when when a customer like White Plains goes and builds those, that's their instance. The only people that have access to it are them. We have security features like bring your own key and encryption and all those kinds of things that truly make it sort of isolated, if you will, in a virtual walled garden, is maybe a good way to think about it as a mental model. But to do what you described, sort of make it available, there's a couple of things that we think about there. So the first thing is, partnering with companies like Life365 that do have that ability to sort of, have a whole business. You guys have a whole business around curating a set of devices that work together in a low-cost way as kits and all of those kinds of things. And then allowing our customers to basically go into their instance of that health data service and say, I want to allow Life365 and these devices or these users or these customers to feed data into my health data service. And then they may go into, maybe they're using, I'm going to just throw some random stuff out here. Maybe they're using Redox as a way to get data into and out of Epic. And I already have that in place. And I want to start feeding that into the health data service as well, so that I can start combining things like demographics with device data for analytics and that sort of thing. And then, I'm a member of a healthcare information exchange, and it has some data that I want to also land in that data repository. So I want to go grant access to that, HIE to allow it to drop data into my health data service as well, and be able to sort of govern and monitor and audit all of that, collection of that data and who's accessing and all of that. So essentially, we provide the services, the platform, if you will, and then we provide the governance and controls and all of those kinds of things around that platform that allow our customers to, provide what access they want to provide. and then limit that or open that or whatever in a way that makes sense for them, meets their compliance regulations and all of that sort of thing. So I don't think about it as the free flow of data in terms of just being able to sort of, the data comes in and then it gets routed to wherever. The data comes in and it gets managed at scale by the customer, but because of the capabilities to share and to authenticate and to provide open APIs and those kinds of things, it becomes easier for me to share than if it's locked up in some proprietary system behind a firewall on premises and all of those kinds of things. So hopefully that made sense. I'll stop talking, otherwise I'll just keep getting deeper and deeper, but hopefully that made sense.
No, it does make sense. It does make sense. Well, I want to get back a little bit on track, and I'm going to go to Michael really quickly. This is a whole topic on hospital at home, but we're getting into a lot of technology and stuff that's needed to be able to support those initiatives going forward. How have users accepted, the transition of care to home? I guess you can do it in context to before COVID and after COVID, right? You're there.
And I think Dr. Jafri should definitely chime in on this topic as well, but certainly we had a minuscule telehealth and RPM presence pre-COVID, without a doubt. I mean, there are few, if any, benefits of what's gone on the past two and a half years, but at least within our organization, it created an incubator for exponential growth of our remote patient monitoring platform and the demand side of having a reliable, consistent telehealth platform, and ideally one that feeds into our Epic platform through some of the things that Randy was describing. But with that said, I think some common barriers that remain but get better with time. It's tough to say a hard and fast rule, because I think it's convenient but inaccurate to, let's say, use age as a proxy for someone who may be less interested in an RPM service, because some devices, okay, they do have a cell hub, so the patient may not need a separate Bluetooth enabled cellular device. But in a lot of instances, like let's say for a blood pressure monitor, for a weight scale, for a spirometer, for what have you, they do need to at least have enough of a baseline knowledge of current smartphone technologies to be able to sync up the device and then know how to react with, ideally know how to react with, let's say, the Life365 portal to view if it's loading in properly, to check their records themselves. I mean, the power of the technology is to seamlessly, almost effectively create this journal or record of vital signs or data that's important or critical for a particular disease process, kind of replacing your old marble notebook or what have you. But there are still patient populations who have a hard time understanding the value of that. There's still some patients, anecdotally speaking, who feel like this might be an invasion of privacy. No, I don't want to share this. Who's getting this information? Who's getting this data? And we have to reassure our population that it's only your providers, it's only your care team, and it's for the specific purpose of keeping you safe, keeping you at home, hopefully keeping you happy. But the barriers, those are just some. I think the acceptance of the technology, the psychological comfort with knowing that someone's monitoring you, but for a benevolent reason. And yeah, just I think each day it gets a little bit better. Again, I'll say anecdotally, we have those patients who are like, oh, I don't want to do this every day or what have you. But my own parents who are in their early to mid 60s, when I tell them the kind of things that I'm working on, they're like, oh, this is amazing. Oh, I'm going to live forever. This is fantastic. I can't wait to let my doctor know, what my blood pressure is twice every single day for the rest of my life. And incredible improvements and new technologies are coming on board every day. Like, for example, at home urinalysis tests, at home blood tests. So a lot of stuff and more comorbidities and chronic conditions are going to be able to be managed at home. But at the end of the day, almost the crux of it has to be a patient's willingness and openness to this process. And that's very unique to every single person.
Yeah, I was going to ask you a question really quickly, and maybe it goes to Dr. Jafri. I truly believe, going forward now, especially with all the data that's coming in from the home, and how we're probably going to a consumer, directed healthcare environment, also value-based care, personalization and engagement, right? How do we build that in to personalize? I know when my mom and dad were living, my mom had 3 computers and 2 tablets, and she was on the grid, and you could connect with her and do any survey you wanted. Dad was basically off the grid, right, from that, and you had to but they both had major chronic conditions. How does engagement or personalization and the use of data that's coming in help with that?
You have to meet the patient where they are. And I think that's an important aspect of this program. And RPM is, before you even think about whether or not you're going to leverage remote patient monitoring or telehealth solutions, are you actually leveraging it to solve a problem? And what we always done before even integrating remote patient monitoring is really do a deep dive as to what is the crux of the issue that we're looking to solve. And based on that, is RPM actually a solution, or is it just something else that we're adding? And for a lot of the areas that we've noticed, medication adherence, diet adherence, compliance, coordination, a lot of this is going to be an adjunct. Now, when it comes to it, what we've noticed is we have a variety of different packages, and not everything is right for every patient. And that's where it comes to personalization. We do telehealth, telepharmacy. Some patients love the telephone encounter. Some patients don't want to be called. And so we actually leverage MyChart or text messaging platforms to reach them. They're not going to pick up the phone. They won't pick up the phone, but they will actually message us repeatedly on a text messaging platform. What we notice is for our patients that don't pick up the phones, they tend to be younger and they tend to be non-Caucasian. So now how do we then engage the other groups, the younger patients, the patients that are non-Caucasian, to be able to do better, to be more equitable? Interestingly, we ran a telepharmacy pilot with virtual pharmacists, and we found that had a higher uptake in our Hispanic population than it did in a non-Hispanic population. So there's really interesting uptakes in regards to some of this technology. The question is, what's the right patient population and what's the right engagement? If they're not going to engage with it, then it's not of benefit. And I think the biggest struggle that we have in remote patient monitoring, we've used it for high-risk chronic comorbid conditions. CHF, COPD is really the eligibility criteria to be on this equipment, and how best can we now expand it to those that don't have smartphones? How do we expand it to those that don't have secure housing, that live in shelters, that don't have readily available internet access? And so we think about active remote patient monitoring, and I think a lot of the future will probably be even wearables and passive remote patient monitoring that will be able to really provide us that information where it doesn't require a lot of the input and activation and engagement that active monitoring requires. So I think there's a lot interesting stuff going on in the future.
Yeah, I'm just hoping, it's my hope and wish that within the next 5 years, we don't call it remote patient monitoring anymore. We call it healthcare, right? So that's just a nomenclature word it becomes. So, Randy, from your perspective, how does the platform that you're dealing with deal with personalization or engagement? There's a lot of data that's flowing through it, and a lot of opportunity to try to learn, right, from the data that's going through. What's Microsoft's viewpoint on that?
Yeah, so if you look at what we've done with Cloud for Healthcare, and you were to sort of boil it down to the what we think about as the solution areas or the tech stacks that are involved in it, there's really 2 tech stacks involved in it. So there's what we think about as our data and AI technology stack. And then there's our Dynamics 365 technology stack. And at first glance, it might seem like those are sort of disparate, because Dynamics 365 is all about enterprise CRM, customer engagement, customer data platform, what you might use to, engage with a customer in a retail environment or something like that, right? And then the data and AI stuff is all about, gathering the data, analyzing the data, moving the data around, storing it, managing, and all those kinds of things. And it sort of seems, again, a bit disparate on the surface. But when you sort of think about it, it's exactly what Dr. Jafri was talking about around and then what one of our participants put in the chat window, which is you have to be able to sort of drive actions and behaviors and changes, and you have to drive action from that data. And so how do you do that? And so for us, connecting that data platform with an experience platform makes a ton of sense, right? Because as the data is coming in, based on that data, you can drive a patient's health and wellness journey through a digital experience platform. So much like, if you're getting ready to go on vacation, you might, go out and schedule airfare, and then, you start getting, information about, hey, here's a hotel discount, or here's a tour you might want to take, or whatever. Well, all that's coming from an experience platform that's sort of watching what you're doing and what you want to do, and sort of suggesting actions or trying to sort of get you to do something. Well, if we apply that to this sort of remote patient monitoring kind of thing, as the data's coming in, and I see, you're on some sort of therapy, and one of the side effects, and just sort of going out in left field here, but you're on some sort of therapy, one of the side effects is weight loss. And sort of you're checking in with your weight, every day or twice a day or whatever, via the RPM solution. And then the system says, the analytics of the system basically go, I see a trend of weight loss here. Well, because of that, I may have a journey that I have pre-configured when a patient that's on therapy or a treatment plan that may have a side effect of weight loss, this sort of journey kicks in. And now all of a sudden, maybe I have a nutritionist call that person or do an outreach, or maybe the patient's preferences in that experience platform says that person doesn't like a phone call, they like a text message. Mm-hmm. So they get an automated text message that says, hey, I've noticed your weight's going down. Would you like somebody to help you sort of think about how to get more protein in your diet or whatever? I'm not a clinician, so I'm going to get way over my skis here about what to do about all that. But the point is that the data coming in from these devices allows you, when coupled with an digital experience platform, to sort of drive those journeys that nudge people and engage people and connect to people. And it can do it in a personalized way because you're storing those preferences. So much like, Amazon shopping knows that you like to order, detergent for washing clothes every, the last week of every month. Like the experience platform knows that, oh, you respond to text messages, earlier in the morning on, later in the week. And so that engagement platform can begin to engage with you in a digital way or in a digitally driven way, according to your preferences and what we know about you and all that. So again, RPM coupled with an experience platform, I think, is really sort of, the utopia of how you derive value out of that thing.
Yeah, I was always going back and comparing stuff to my mom and how she would engage and stuff. And my dad too, I go back to that experience and poking out and going, well, do they engage through a text message? No. Do they engage through a smartphone? Yeah. So let's go that direction with them, on a smartphone instead, but also building incentives into it as well. Like if you gave my mom, a Silver Sneakers membership, she's not going to be incited. But if you gave her a Netflix subscription, she was ecstatic, right? To be able to do that because she didn't only walk 300 steps a day.
Yeah, but bringing in about that also is, and I think there's a comment in the chat box that I thought was very important. All this talk about data, it really comes down to what's important for the patient and where do they see themselves in regards to their understanding of their goals. One of the things that we talk about with our team is when they do their initial interview with the patient, they understand that what is important to that specific individual. And oftentimes for that patient, it's not, I don't want to come back to the hospital in 30 days. It's something more along the lines of, I want to be able to attend my daughter's wedding and walk down the aisle, in 2 weeks, right? Well, what do we need to do to get you there, right? And if we really focus it on quality of life and what's important to that individual, I think that's what it comes down to. And sometimes what's important to us may not be what's important to them. And then that really comes down to, where do we focus our attention? And I think that's really what it comes down to. And how does RPM help us there? So I think, behind all this data, really the crux of this is what's critical for that patient, what's important to them, and how do they envision their goals?
We're going to go just for a few more minutes, but Michael, there was a question also about passive technology as well. And I think there's a lot of 80-20 rules here, like, can we use 20% effort to get 80% of the bang for the buck? Can we just nudge people into compliance? So data that's coming in from like the Apple Watch, right, is that data that's enough to be able to get a patient compliant in their therapy at home, right? Do you get useful data out of that, out of an Apple Watch? Do you see Apple Watch getting to a point where you can use it passively on the wrist to be able to collect data, to be able to manage care at home?
It's funny that you use that example. We haven't engaged with them specifically, but we've engaged with other startups that created a similar device with mixed results about the quality of the data. But assuming the data was reliable, whether it showed a patient's recent propensity for fall, a patient's hydration status, because it has gesture technology that monitors, when you put your hand up to your face, capacity for, if it's someone with dementia, a simple GPS device for if they're outside of whatever we program is a safe space for them, or their home. The short answer is yes, there's value in it, but to truly maximize that value, there has to be also engagement, or maybe more likely monitoring on our side. If we presume engagement on the patient side, and if we presume accuracy of the data on the device or technology side, we're like 80% of the way there. And then it's just a matter of doing the monitoring on our end, setting up the correct reports with the correct triggers for what we want to be alerted to. And essentially it's off to the races. Specifically for the Apple Watch, as I said, we haven't engaged with them as partners, at least as yet. But based on what I know its capabilities are, a lot of the data points they're collecting are absolutely useful to us. It's just a matter of, is the patient on board with getting a phone call if they go a little bit past where they should be? If they get a phone call or a text message, if, hey, I noticed you haven't drank any water today, or I noticed that you put on 5 pounds in the last 2 days and you're in our CHF congestive heart failure pathway, we're concerned about a potential readmission. Were you eating some salty foods yesterday, or drinking too much water? Were you aware that you were on a fluid restriction? So there's value in it for sure, but it really is like a partnership. That's what it boils down to. Both parties have to be interested and aligned, as Dr. Jafri was saying, in what the goal of the care is. Because if it's not, then we're just going to be another phone call checking about your car warranty that they don't want to take.
This is the last question, because we got to cut off here, because you guys are busy guys. So one of the questions I had was, are patients willing to pay the copay, or willing to pay anything towards being monitored at home? I know one of the big resistance for the CPT codes is that, and I know you guys aren't billing, I don't think, under the CPT codes. Are they resistant to paying copays or paying for equipment to bring this into their home for their self-care?
I might be best suited to answer that question. So while we focus primarily on, or I think exclusively at this time, on Medicare established patients, Medicare does pay for these services. We've established the billing parameters and the billing process. What we're doing more recently is internally figuring out with our own, we're blessed here at White Plains Hospital to have an internal data analytics team that takes information from the Life 365 platform and tracks something that would be really untrackable by person, such as, okay, your first data point was collected on day 3 of this month. Every 30 days, assuming that you collect X amount of data points, we're allowed to drop a bill for each subsequent 30 days. And then doing that times 20 or 30 patients, it gets complex real fast. But the short answer is we've focused primarily on Medicare patients where there hasn't been an issue. But once we can show not only effectiveness, but scale, I think it should roll out absolutely to other areas as well. I think I touched upon this earlier. It's the device costs in comparison to the potential benefit is minuscule. Really, the only cost or the cost that's on our radars as a provider is the labor costs internally.
Right, makes sense. Okay, we're gonna wrap up, so I want to go to Dr. Jafri. Any last comments, about transitioning care to home?
No, I mean, I think we covered a lot of the areas here. I think for me, the biggest area is 1, making this patient-centric, 2, making sure that we give the right device for the right reason, 3, that it is really a co-monitoring program. And finally, with our stakeholders being the patients and also the primary care physicians, how do we provide data that's actionable, that's meaningful, that's palatable, that's digestible, that's the right data at the right time for the right reason? And I think if you could get that down to a science, this can really be very impactful.
Awesome. Randy, closing thoughts?
Yeah, I want to go back to close to what you said about, co-pays or patient pays or whatever. I think if we figure out how to combine the things that we've talked about today with the idea that the patient wants to walk down the aisle for their daughter's wedding, as an example, and we're able to equate, hey, you take this treatment, which includes RPM, and you engage with us through this sort of these digital channels, this automation, all that sort of thing. Who wouldn't be willing to sort of contribute to that, right? Like, if I do this and if I help, then I'm going to get to do what I want to do. Then I think if we're able to sort of wrangle this thing where the outcome is the patient gets to do what they want to do, gets the outcome that they want, not just, oh, I'm staying on weight, but because I'm staying on weight, this happens, then I think maybe they do.
Yeah, it's interesting. I'm gonna close up, but I would gladly have paid whatever with my parents, in independent living instead of keeping them going to assisted living because it saves thousands of dollars per month. My mom wouldn't allow it to be paid, right, from that by the children or otherwise. And we are asking CMS, the industry is asking CMS to drop 2 things. One of them is the copay, because we do think that's a barrier to scalability. And the other one is the 16-day requirement for readings that are out there, at least drop them down, because you want the patients to be engaged, but 16 days is quite a bit to do. And that means that the physicians and the health systems have to really super engage people to take their readings all the time, right, as well. So those are things I think you'll see in the next couple of years that will probably change and help with scalability, right, from it. I want to actually thank everybody again for attending this evening, and thank Randy and Michael and Dr. Jafri for your participation and great insights. We'll post a recording on New Normal. It'll probably be out there tonight or tomorrow. Our next episode will be entitled The Role of Technology in Healthcare, which is April 6th, next Wednesday, hosted by our Chief Technology Officer, Mario Basu. And we hope you join us, and you find the registration detail also on New Normal, but you'll also get an email as well. So thank you for joining us, and have a great evening.
Thank you.
Thanks, guys.
Would it be all right if in the meantime I asked Randy some questions?
You can, wait, people are filling in.
For the podcast. Oh, perfect.
Yeah.
So I may be working with some of your.
This is live, by the way, to everybody.
Oh, no,
Yeah.
I'm not going to ask him what he drives or anything like that. No, I may be working in the near term with probably your far downstream direct reports, but we recently had some demonstrations of teams on fire with some, I don't even know what to call the teams, but through Mario and our connections with Life 365, we had some really powerful demonstrations of some capabilities of the Teams platform in a healthcare space. But I am excited about where to take that. And I was probably going to talk about some of those things during the podcast, because from my point of view, you know, what Kent and Life 365 provide is phenomenal as a platform. But the real issue and growth in this field, at least in my perspective, it's scalability. You know, the CPT codes for this kind of stuff, ultimately it'll cover the device costs, but unless you really, really scale up some of these RPM programs, you're never gonna forget about necessarily profitability, but to hit net zero for the labor demands of these RPM programs, you really do need to have, you know, 50 or 100 patients per nurse practitioner or per PA or per physician. So I'm particularly interested in your work, Randy, just because figuring out a way to make these programs scalable is huge. And I think it's the next step in a lot of remote patient monitoring.
Yeah, I don't disagree. And I think that's just looking at our agenda for the talk today. I think we'll talk a little bit about that. But to your point, the scalability, the reason Microsoft and Life 365 are really working together is Life 365 brings the scalability of how do you get the devices to the end patient and get them wired up and connected and get the data flowing and all that kind of stuff. And then what Microsoft provides is a platform to land that data, to activate that data. And that platform provides a ton of automation around that activation so that you can scale, you know, a smaller set of caregivers to a larger patient population, because much of the activation that needs to be done, whether it's, you know, looking for outliers or you know, managing workflow or whatever, can be automated in the platform based on the data as it comes in, or analytics of the data, you know, over time or whatever. And so it's a big part of why, you know, Microsoft and Life 365 have decided to work together, because we bring the scalability of the data platform and, you know, all of that kind of stuff, and they bring that scalability of you know, the devices and their connections and their logistics and all those kinds of things. So absolutely.
I'll give you a hard time, Randy, but from what I've seen, the best analogy I could give to it is only Microsoft could do this. When I first saw the demonstration of the Teams on Fire platform, it was as if you guys were building cruise ships before you had decided on which routes or courses they were going to take as yet. Because with some of the demonstrators, they were asking questions such as, you know, what were the use cases and where, you know, would this be in the ambulatory space or the inpatient space or the RPM space? And what are the concerns on the provider end? And we're happy to provide the answers to that end, because as you mentioned, I think Life 365 and Kent's group is providing the platform. Microsoft is providing the scalability, and sort of the last piece is I don't want to say automating, but at least streamlining the workflows. And those are the kinks we're kind of working through right now. But with the tools I believe your team makes available, I think the gap is going to close very, very fast. I'm excited about the field.
Yeah, and the Teams on Fire that you've seen is really just a vision demonstrator. To, you know, we'll talk about this, I think, a little more during the webinar.